Welcome everybody to today's webinar from the DIDAS Health Working Group. My name is Peter James. I'm heading up the working group and I have the pleasure to introduce my colleague Dominik Geller, who is going to present his solution to us today. Dominik, thanks a lot for joining and the floor is all yours.
Thank you, Peter. So I'm here today with Ivan, my co-founder here in Hygiaso. I'm going to talk about us providing health data services which are secure and help to improve the healthcare system or the ecosystem around health data sharing. Specifically, we are active in 4 domains. We allow to automatically code health data, unstructured health data, a domain where there is huge effort today invested in work in harmonizing and structuring data. Secondly, we make unstructured health data reliably searchable and queryable in natural language. And with these type of tools, we are able to recruit eligible patients to studies, matching those studies 10 to 100 times faster, depending on the study. And we also provide tools to securely transfer health data end-to-end encrypted amongst the different actors in the healthcare system. So today you will see a certain part of our kind of value chain and the processing that we provide. So from the very left, we take patient level data in any format at the individual level that the patient may have collected or at the clinic. Depending on whether that's image or already text, we OCR that, we de-identify that if needed, and then we automatically code that and make it reliably searchable and queryable to the user, who can be the patient, who can be a clinician or a researcher. Subsequent steps we will not show today, so notify studies, obtaining consent, or the actual sharing of data as a result of that. It should be noted that that part on the left, knowing the constraints and preferences of clinics, we can also localize that type of processing at the clinic or in their private clouds if so needed. And we also can deliver directly certain data formats, such as FHIR data, if that's required. Us as a company, we provide such. We are certified for information security and data protection, so we have kind of rigid controls and safeguards to make sure our processing is safe and per our promises. On that latter part here on the chat, I think what you will see today is how you can chat as a user, if you're a clinician or a patient or a researcher, how you can chat with your data in natural language and get the output that you want, including references to source data. How you can use that to analyze patients' data, your own or that of your patients as a professional. And then you will be able to see how that can be used to also drive the other use cases I referred to, specifically matching study proposals or eligibility criteria with patients, and also the transferability of that use case to screening for quality or safety events, screen for reportable or rare diseases, contraindications, policy or guideline compliance. You can also imagine how that could easily be used then to expand to screening for relevant publications to a patient at hand for quickly getting the latest treatment options. So I already alluded to some of those use cases. We cut the effort in harmonization of data. We make the unstructured data, the PDF documents basically, queryable and searchable with a natural language interface. The study matching, those are kind of the use cases for researchers and project managers. And for the clinicians, we enable them to quickly evaluate their medical health records at the clinic or as an individual, their own, which they may have collected, including the unstructured reports. You can also think about multiple clinics to run population health analysis amongst them, not just at one clinic, but also across them, which offers also bigger scale population health capabilities if needed as we reach certain size. I think that's the quick high-level summary of what you're going to see. I do have subsequently kind of details for each of those use cases, which I can share either individually after the demo, or if we have time, touch and refer to that depending on the questions you may have. I think at that point, I would already quickly jump to the demo and hand over to Ivan so you can actually see how this works.
I'll start off with the one that's already running. I'll just jump straight into chat then. So what's happening here is that the data that's behind this is basically already extracted, and it's not an LLM hallucination or something like that. So what you're going to get is always backed up by data. So if I say what are my patients, will basically go and fetch everything that it has on record. I mean, what you see here is a little bit of again debug mode, so you can see what's really happening behind it. But of course, we have another version which would respond in a more human way. What are my conditions, maybe? And you can see that we have a mix of languages and also some codes that we try to get every possible code that we can get, but also using UMLS to just have a unified code and say, close enough. We saw that there was LDL there, so let's say something like that. And what it does, it takes all from different documents, it will take all the LDL measurement points, and based on that data, we can produce graphs. Right. Okay. So basically, we can do this, and other things like checking for anomalies, checking for outliers, and or basically we can do all sorts of different analytics that are based off of this. And well, we already have that in one of the newer versions. This paints the picture a bit.
All right, so are you opening already for questions here, Ivan?
Basically, you get the ChatGPT kind of interface with the data backing up those claims, and not just getting a bunch of documents and ingesting it with LLM and producing the output. We have future integrations with other knowledge-based systems. We can verify against those. Like we can get the clinical practices that are common today, and basically trying to get everything backed up by data and not just imagining things.
All right, so this is the current development version that you have seen. I understand the latest developments have not been deployed yet. That's why I think you have been a bit shorter in what you were showing. You have seen this is also available in multiple languages, so you can query in whatever language. And that means the interface language as well as the language of the document can be in different languages, identifying the concepts. You have also seen that the accuracy of identifying some of those concepts like medications are not yet fully accurate, so we need to fine-tune also the hit rate in terms of making sure we differentiate terms that are actually medicines and medicines related terms. So those are kind of fine-tuning things that we need to still adjust. But I'm not sure whether we can show that as well. The ingestion of a document, is that demonstratable as well?
Yeah, so any are extracted. Okay. So it also did some other extractions in the background, sorting it to different databases so we can query it faster. So now if well, this is one of the new versions of the endpoint. So if I say show my medications, takes some time, right, to process.
Can you zoom in a bit?
Oh, sure.
Thank you.
Okay. So here you will get a more user-friendly response. You get some suggestions on what you can do. Of course, this depends if you want to block it or not. So currently, I'm blocking any advice that is medical. So how often should I be? I'm being very restrictive right now. I can't give you any advice. I can only do the analysis of the data. If you try to type something which is unrelated, it's also not going to work, and so on and so on. Yeah, here is your medical summary, for instance. And then if I say show my LDL progression, this is alternative for the user. So obviously I had a lot of exams on the same day, different time. I mean, it's all synthetic data, so you can expect that it's not very real looking. But you also get the analysis out of this. So some basic calculations get out of data. And all of it is still just backed by the real data. You can trust that these numbers are coming from basically structured data and not just again ingesting documents all at once. If you had a couple of documents, I think LLMs would do it reasonably well, even that it's not a calculation but imagination. But we do have some collaborators which have a lot of data points. And I also know people who have over 5,000 documents. Processing this with LLM would be basically impossible or very costly. I'm not sure if the results would be that good. And here we can do this in a matter of, well, the calculations would be milliseconds because they're data calculations and it's not a generative approach. And yeah, Dominik, you said the language is sure.
Another language.
This works.
If we have that on record.
Well, it doesn't matter. Should respond. There you go.
So we know the response is in the same language as the question.
I mean that's another interesting one because there we go. If the language is supported in German, we can get entities and codes very, very reliably. If it's a language which is obscure, we also handle it by automatically translating it and extracting, but marking it in such a way so you do know that it didn't come from the original language. Everything that's extracted has certainty levels. If you make a query analytical perspective, so not just as a user, say a researcher, then you would be able to find the results which are, I don't know, above 99% or above 95% with confidence which is above this level. So you can, depends what you want, how strict you want to be with your analysis. You can use relationships as well, like find me the patients who have this condition and I don't know, smoke this much, but have not been smoking for more than this many years and made a pause between this and that. And we basically query the database for these results. So we can we can analyze massive amount of data like that.
Now, so you see, this is not quite included yet in the product. We need to deploy that part of the functionality into the product to be released soon. I think the ambition is still to give this out to beta user testings before Christmas. So this is coming. I have in the presentation also a barcode that you can scan if you want to register as a beta user and try this yourself. So we make that available. What I can offer now, I can either now relate what you just have seen to the different use cases in quickly wrapping that in the presentation, back in the representation, or open to questions already now before doing so. Otherwise, I could handle questions at the end. Any questions? There was one. It already disappeared. So let me take, Ernst, let me take the one, okay, from Gerard. So currently we digest documents of any text format, PDF, not yet Office documents, but we will also absorb Office documents and image data. So we can also parse text from image data. Ernst?
Yeah, thank you. Ivan said something very interesting, that you are not using LLMs to extract data. And I want to hear more about this because I was talking to Alex Komorowski, sort of senior Google official who has now started his own company called Common Tools, together with Bernhard Siebold, the Swiss guy who invented Google Maps. And he said, and I'm convinced that LLMs, what they're really good at is taking any kind of data and structure it in any way you want. And of course, everyone, including myself, uploaded my medical history, my recent medical history into ChatGPT and asked them to do all the things that you've just did. So my question really is, what's different, what you've done and what LLMs can do anyway?
So if you uploaded a couple of your documents and used LLM, that's going to work good enough, I would say. There's marginal difference of maybe sometimes something is not 100% accurate, but I would say that there is no difference there. What's different here is that you can take a lot of data. Like say, if you had 5,000 documents and not just 5 documents, using the LLM to process that would need so much context that you would basically not be able to do it. So you can see it as like in case of a lot of patients, even with 5 documents, this would not work anymore. So if you're at the radiology department and you have millions of reports, this is not going to work. And even theoretically, if it did work, if you start processing it slowly, the amount of data you would have to process is very expensive and very slow. So that's
what are you doing
to mitigate that? We are extracting entities out of documents and have relationships, have graph out of that. That's one of the elements. We can capture this in a semi-structured way already like that, and a lot of other steps which make it possible to unify different units and well, the ways that people are describing the data, even in measurements, it can get a bit messy. A lot of pre-processing so that I mean, I know that when you see this is just looking like a regular ChatGPT interface. So it's just a lot of agentic work happening in the background to get you this. And again, if it's just for one user, a couple of reports, I don't think there's a huge value, except unless you really want to know like 100% that what you're getting is correct and trace it back to where it came from. I mean, I'm not showing it here, but basically everything that comes here, we can link it. We can say this is the place where it came from. But again, if you have 5 reports, this is irrelevant.
But from a person point of view, if you upload your individual documents, and I did it with about 100, a zip file of 100 documents out of my EPD, it worked like a charm. But on the other hand, what you're doing, as I understand it, I'm not sending all my medical information to OpenAI, whereas, of course, and so I think that is an important difference, right? I'm always wondering how can I use this great resource, but without feeding OpenAI or Anthropic with these with my data.
Yeah, your data will not be used for training.
Absolutely. So I think to summarize, we do use LLM for the extraction itself, as well as for the query generation to the database, isn't it? For certain,
I would correct you there, because using LLM for extraction is exactly what, to a degree, like for some things, yes, but the most important parts are a different approach.
the other aspect is the scalability of what we are offering here. So this works also at clinics and across clinics. If you think of EPD, Ernst, we can basically evaluate the PDFs in EPD like that and could offer an interface to the doctors to query the EPD history of a patient that they currently see, if we link that up. So overcoming the PDF graveyard is what we can.
No. That's what that's what I see. That's what I saw with LLMs. PDFs are no longer a graveyard. They came to life, and all these efforts that DigiSanté is doing in standardizing and blah 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 is ridiculous, because in none of their programs they really AI or LLMs is even there. So that then I stop. That makes me crazy.
May I quickly chip in here? So we quite dynamically shifted from the demo to the discussion mode. So first of all, thanks to you both guys for showing us your early version. So that was very much by purpose an early version, and that's basically how we played here in this group. So it's rather informal. I would like to. So first of all, I did a similar prototype many years before ChatGPT came to the market. So expect some in-depth questions from my side. But coming to the point of Ernst, and that's about the quality, how reliably you can recognize the data. And so it depends a little bit on how you do it, but the quality is, if you take it from free text, it's not 100%. So you always have some guesswork depending on the quality of your training data. And Ernst, I would strongly object that AI is solving every problem now. So my usual response is, it can do a lot. It's really good, very helpful in searching, in analyzing, but for medical data, I think for the years to come, we always need the human in the loop. And it's about curated data. So you can do a quick first analysis, but I think to be sure that the quality is on a level which is sufficient for any sort of medical advice or treatment. Honestly, I would never ever go to a surgery where the analysis comes purely from AI. So
it will never happen anyway.
Yeah,
AI is developing so quickly that we have to endorse it and embrace it right now, even if DigiSanté doesn't do it.
Yeah, I'm not against AI. In contrast, so I think it has some really helpful elements, and that's actually one of my key questions here. And then I have another one. So what is your quality of or reliability of identifying the correct information? So let's take an example of a document, a sloppy document from medical doctors, and these documents, they vary from little artwork to total crap. So if the source is not very reliable, AI can't do a lot. So where would you put your reliability in recognizing the data? So basically making sure that you have the correct positives and the correct negatives. Can you make a statement on the quality of your recognition or reliability?
Maybe Ivan, you start and I can add.
Well, we don't have the exact number because we are using a lot of different techniques. Each one of them adds up to the total. And some, as you said, some reports, the human factor is what makes a lot of mistakes. And I mean, I've seen it many times, like just messing up the dates, messing up a lot inconsistent reports. Like one time you have your appendix, and then 2 times you don't have it, then you have it again, and this keeps happening. So of course, how do you handle it? That's the question, rather than can you figure it out or not, and with what techniques. So in terms of extractions, like getting entities out of this, again, with non-LLM approach, it's close to 100%. What's capturing the relationships is then what makes things trickier, and also it is quite hard to say if everything was done. Depends how you measure it.
Okay. May I quickly ask a follow-up question? If you say non-LLM, so if I get it right, but correct me if I'm wrong, what you're obviously doing, you're doing a named entity recognition, so extracting the context, and then I take it you're building a knowledge graph behind the scenes. Is that correct?
That is correct. But this is one of the data sources. So like, of course, it would be silly not to use LLM to try to consolidate some of the things. And so basically, we are trying to do everything we can to get a higher accuracy and better searchability and so on, performance as well, because
that's exactly
the scale
point.
matters.
That's exactly the point which I would like to make. So if you're building a knowledge graph behind the scenes, then you're actually establishing a structure which is not available in the free text. And that's my message about the curation. So that's the discussion which I'm having with DigiSante and the others. Where we need to go is we need to capture the best quality of data at the source. So as you said, it's a human factor. If you have a doctor who is sloppy in writing his report, then you cannot get out more than it's in the report. So
of course, I mean, we are not backing up for the doctor to do better reports as such. We take the data they inputted. We are not inventing anything on top of that.
Yeah, I fully appreciate that. We have tons of free text reports which need to be analyzed, but we have to be aware, and that's why I'm asking the question. We have to be aware the quality is only as good as the source.
So, of course, but that's beyond what we can offer here. We are not improving a training or providing a tool here which takes errors out of the healthcare system altogether. We are digesting the data that has been produced by professionals for evaluation, for clinicians, for researchers, and for patients. And that we do to a high degree of quality.
As reliable as possible.
As reliable as possible. We could use the tool to identify inconsistencies, issues in the data, but we are not auto-correcting it. We are not hallucinating around that and making up data points. but we make it reliably searchable and queryable. So that's the service that we offer. And the claim that, let's say, the humans are better in doing that versus the machines are better at doing that, I think that's to be proven. I would not want to make a statement here that we do it better, but equally, I don't just accept the statement that the humans are better at doing that. I think that's a good pilot to run, and we would stand ready to actually compete on that. I have quite a high confidence in the output here, knowing that we can reference every data point to the source document. So that trail is available. So to be seen. We don't have a head-to-head study comparison.
That's why I'm objecting Ernst's statement. So it's only as good as the sources. That always needs to be added.
Of course.
You need to turn your mic on, Ernst, if you want to make a statement.
No, I think my statement was clear. That's obvious, as Dominik says, you know.
Yeah.
But I think you will be able. As I will say that LLMs in future will also recognize data quality.
Yeah, that could
by being consistent, by testing consistency, etc. I think that's all possible.
Or missing data quality. That's if you have a sloppy report, then you have obviously missing some data quality.
Yeah, but you can recognize that. You can recognize a good and a bad report. I mean, it's like grading an essay from students. You know, you can.
I think it's worthwhile, so I can maybe take what we have seen now and put it into context of the different use cases, just to make sure I frame that so you see the potential. So what you can see is a couple of things that we solve. So this expensive structuring and harmonizing data efforts that everyone is engaging into now, still, or for years already, we can at least help that process and accelerate automatic process, if not eliminating that. And we're ready to kind of demonstrate that in a pilot. We can do that at clinics to make sure that we can accommodate the sensitivities of the clinics of not wanting to leave their data from the site. You may have seen now or can actually appreciate that with the possibility to query and evaluate PDF and text documents that are not structured, we have the tool ready to overcome the data graveyard, the PDF graveyard in any of those records, and quickly make that available. And if you can screen for questions like that, certain eligibility criteria to a study or certain characteristics of profile, you can use the very same tool to screen for contraindication, guideline deviations, quality or safety issues that happen at the clinic. That becomes available with this tool instantly. And that's how we can also improve quality at the clinic and also to the clinical practice. A second aspect, if we look at the clinicians, then there are studies that show that up to 1 hour per day, they invest into searching for data points in the health records from patients they have to treat. If they have now a chat interface where they can directly query that, we save them time. Directly, they can basically, rather than browsing through PDF documents, they can ask a question. They may have a quickly, if it's coded structured data in the EHR data, they may have certain values instantly available as well. But we can complement that with unstructured data from reports, which otherwise they would have to browse and screen manually. You can also see that with this type of tool, you can now quickly screen for patients that are eligible for certain studies that you want to recruit. So for research sites, this is an essential tool to accelerate their discovery and screening process. And for sponsors, that will improve the ability to recruit on time and reliably, because you can instantly screen for how many patients you have at a certain site, and that accelerates the recruiting. You can also see things like, hey, if you want to also exchange data with your peers and transfer data to another colleague, we already have now the ability to transfer health records of large sizes. So we're talking here hundreds of gigas if needed, from one side to the other reliably end-to-end encrypted. So we can also provide a tool here for transfer of sensitive data across sites. That you have not seen, but that is something that we had to develop also for our application here in order to get into the clinics and to allow patient data sharing amongst patients and professionals. So you see, there are quite a number of attractive use cases that become available this way. If you think of multiple clinics to be collected, you can also envisage this to be used as a population health tool, where you can see, hey, how many patients have been on record now in the last week with certain infectious diseases. So this type of symptoms monitoring across populations at the clinic or across multiple clinics become also a very viable tool for population health monitoring and health technology assessments as well. So we will be ready to install this on pilots and test this with clients. We are a competent team with competent advisors. And you have here, I promised you this barcode. If you want to register as a beta user, you can do so, and we will notify you of a release that you can try as an individual to upload your health records or health records that you want to try this with, and then give us early feedback as to what we should improve, change, and gain your own experience on the utility of this new tool that has the potential to be quite disruptive to how we deal with health data in the future at clinics and for research. Are there any further questions?
I have a ton of questions, of course. So I would assume you're running that locally. So that's obviously possible with today's technology.
Well, we are offering to run it locally. We are not currently running it locally. So we can put certain steps on-prem or in a private cloud. But currently what we will make available is an offering which we run cloud-based, so that individuals can upload their data and evaluate. But we are not running that on the individual laptops of those individuals.
But I would assume in the infrastructure of a hospital, for example, you know, I've been playing around in this field for a while. So one of the most challenging parts will certainly be to integrate that in today's primary systems, be it a clinical information system, or if you're with a general practitioner in his local system. Are you in contact with the providers of these systems, or how do you plan to integrate that with existing systems?
Hurdles that you mentioned are organizational and political hurdles, not technical hurdles. So anyone who wants to have this implemented and is kind of willing to engage in a joint project here, then we can overcome those hurdles in a bilateral agreement here. But we are not just offering one approach that should fit all, because it's quite a heterogeneous landscape and you need to adapt in each case. So we're flexible to do that. We know that we can deploy certain elements out of that value chain that you have seen locally, but that will depend on the needs of the respective counterparty.
As I mentioned, I implemented a very similar prototype a few years before ChatGPT. And that's exactly where I got stuck. So technology, usually you have it ready quite quickly, but if you need to integrate it into an existing environment, that's usually where you have the effort. That's why I'm asking this question.
Yeah, but don't ask me to comment on the infrastructure environment at every clinic here. I mean, we have to live with what they have and then adapt.
Yeah, I think the best approach would be probably not with the clinic, but with the provider of their system. So in the clinical information system in Switzerland, you have somewhere around 10 relevant players, and with the doctor's office system, it's about similar. So you will have to work with them to have it integrated.
Whoever wants to partner.
Yeah. And quickly coming back to my previous comment about capturing quality data at the source. So we all agree with the existing written free text documents, it is what it is. But if you think one step further, if you're building this knowledge graph in the background, basically that's how you build the structure. If you do that in real time, while the doctor is basically either typing or dictating his report, you can at that point advise him what's missing or where you have ambiguities, and then you have good quality data at the source. And the really nice thing about this is it's a reliable source because it's validated by the author of, so you have the provenance information with it. You could even digitally sign it, and even better, once you have it in a reliable quality at the source, you can automate most downstream processes. And that's actually a selling point, because one of the biggest complaints of today's physicians is that they spend too much time on administration.
I think there are many problems in the healthcare systems. We are not aiming to solve all of them, but some. So I think we need to kind of focus as well, otherwise we're losing ourselves. But I don't disagree with what you said, but that's not what we are providing here. I realize we have a couple of questions from Gerard and also from Ernst. Maybe Gerard's question first, because it was first. Ivan, can you comment on the lab results? It's in the chat, the question.
Yeah, I can summarize it. I'm actually mentoring a company, the founders of a similar company in another industry in Switzerland. And one of the things we are discussing is the extraction process. If you recognize the document a little bit, the type of document before the full OCR extraction, then you can get better quality extraction by being a little bit document type specific. And I was just wondering if you've done some work in this area.
Yeah, that's the OCR part. So if it's generic, we try to extract it to figure out what's there, because you have some tables. It can be structured in various ways. So you have to ingest it. Ideally you would know how these elements are correlated. And if you do know the document type, which is as time goes more and more, you can make it perfect. How we do it right now is quite good. Yeah, but you're correct. If you know what the type of document is, you can get much better extractions. And yes, we do incorporate that.
So you have some of that idea in your extraction process.
Definitely.
Okay.
If you know exact pattern of the document, then you can check if it's one of the known patterns and make it very, very accurate. But if not, then we deduce what's what and still do it, but just slightly less, with a little bit less accurately. And then
thank you.
There was a question whether we can use genome data, for instance, from 23andMe.
Sure. I mean, it's quite a lot of data, but we would have to integrate it though. But I don't see the limitation.
So we can, but do not yet.
That is correct. Yes, but that's the beauty of it. I mean, it's we can link up anything to different techniques to give your results back instantly. Again, the value of having a lot of these data points so that you can use it for participant discovery or something like that.
So if you're saying you're giving the results back instantly. That means you're basically pulling it from the knowledge graph which you have prepared.
Well, the different techniques. I mean, like I don't know if genome data. It's not very close to me. I have not worked with it. I know that a lot of analysis has been done. We can hook up those sources as well, but technically, I don't see the challenge.
So time is flying. So that was really quick with this 1 hour. I didn't even realize it. So then let me conclude this webinar of today. Thanks a lot for both of you, Dominik and Ivan, for showing us your early version of your solution. Very interesting. Thanks a lot. And for those of you who are interested, you can subscribe to the channel or you can like the webinar so you'll be notified for future webinars from DIDAS Health. With that, thank you very much and looking forward to see you next time, and enjoy your Christmas holidays.